Hello, everyone, and welcome to episode 27 of What to Think, the technology news podcast from VentureBeat.com. I'm your host, the editor-in-chief of VentureBeat, Dylan Sweeney.
And I'm Mark Sullivan, writer at VentureBeat.
Today we're going to be talking to Aneesh Chopra, who was the first chief technology officer of the White House and has gone on to work with Box and Hunch
Analytics.
Hunch Analytics, that's right. And he is a consummate health tech insider. We're going to have a really interesting conversation with him. But first, some tech news highlights from VentureBeat.com. Let's start with HealthBeat, VentureBeat's health tech events. Tell us about that one, Mark, because you were covering that a lot. Like, that's your beat.
Yeah, that's my beat. I was there and very busy. I was pretty impressed, actually, about the conference and sort of the level of energy around digital health, and especially because we started off the conference really strong on Monday morning with Aneesh there and our friend Aaron Levy from Box, talking to Bob Kocher from Venrock, who helped write the Affordable Care Act. So just some really big brains in the room, and just these people are, people in that space. They're people that they talk about and refer to, and they're real thought leaders. And not only that, but these guys all knew each other, these guys on stage.
Those three in particular had quite a discussion. Yeah, it was lively. Caffeinated.
It was caffeinated.
Super smart.
Yeah.
So what would you say were the big takeaways from HealthBeat for you in terms of,
I think there were a few major themes that you kept hearing over and over, and it's really interesting because everybody knows that the healthcare system is broken. There's a lot of money is spent on just waste, and the cost of healthcare is very high, and it's also an antiquated system. It's just an industry that IT and new thinking and technology hasn't quite visited yet. And so
anybody who's been to the doctor in the last couple of years has witnessed the spectacle of doctors struggling with their new digital health record systems, right?
Yeah.
Which started out being really kind of annoying, like filling out forms on the screen and stuff. They're getting a little slicker, and a lot more of them are digital now, right? They've actually made that transition.
Yeah. The government has incentivized this by paying doctors to implement computer-based patient records and using them in meaningful ways. But the truth is, doctors, for the most part, are just getting, especially in ambulatory care or clinics, are just getting used to communicating with each other in this way and documenting care in this way. So, and it's just surprising to me. It occurred to me during the conference how much is riding on this. The idea of getting all this into clinical information into a record in a way that can be analyzed and shared over, say, a cloud platform.
Right.
And there's just a huge amount riding on this, and it's still kind of underway.
Right. They might have the digital records, but the record system might not yet talk to another doctor's digital records.
That's actually a huge
problem. To the CDC, if the CDC needed to kind of coordinate around, say, an epidemic, right?
Yeah, that's one of the issues that came up. It's something not a lot of people have talked about, but the coordination around that data is super important.
Okay. There was also some cool stuff around wearables and using data to improve.
I mean, I'll kind of tackle two different themes here. There's a lot of people are talking about. Actually, there's a lot of different. We're about to be deluged with different types of data. And one of these types of data is, you got the genomic data coming in. We're just figuring that out. And then we got all these people wearing devices around, which are, counting steps. And so all that data is coming in. So a lot of people are worried about how we're going to handle all that data and make it meaningful to doctors so that they can provide not only better care, but more cost-efficient care.
So your Fitbit or your Apple Watch might not just be a way for you to rack up more steps per day than your brother-in-law, but it could actually be a tool that would feed into a treatment plan or health plan.
It could provide some kind of an early warning system for your doctor. It could raise an alert in his office if something's going wrong. And all we're doing now is counting steps, and some of them are doing heartbeats, but it's going to get a lot more advanced than that. We're going to be doing blood oxygen level and all kinds of crazy stuff with these things.
Okay, cool. Check out VentureBeat and search for HealthBeat if you want to check out some of Mark's great coverage or our other writers' coverage of health tech and HealthBeat. Really interesting field in which an awful lot is happening in the next few years. It'll be fun to watch. Let's talk about Microsoft real quick. They made an interesting move this week where they increased the amount of storage available on OneDrive from 1 terabyte to completely unlimited cloud storage if you're an Office 365 subscriber. Now, that's not free storage. You have to pay $7 a month or maybe more depending on your subscription, but you get unlimited storage. As if 1 terabyte wasn't enough. You get totally unlimited storage. So this is just sort of interesting that cloud storage is now so cheap that they can give you all you want.
Yeah, it just seems like it's a sort of a race to zero here. I mean, it's. I think in the background, this is a pretty high stakes war for the enterprise, and so this is just part of the tools in that battle. But yeah, it does seem like it's getting incredibly cheap, and it's hard to imagine how you would use that much.
I have no idea. I'm sure I couldn't fill up 1 terabyte. By the way, both Dropbox and Google offer 1 terabyte, but they charge $10 a month for that. I can't help but think that both of them are going to respond pretty quickly and raise that limit to unlimited.
That's what happens every time. There's this ratcheting down and everybody has to play. So,
all right. Well, I don't know what to do with a terabyte of cloud storage, but I do know what to do with a flying car. And fortunately, our reporter in Europe, Chris O'Brien, is at the Pioneers Festival in Vienna, Austria this week. And he saw a startup there called Aeromobile, which is from Slovakia. And you bet you didn't know that Slovakia was a hotbed of aeronautical engineering, but they are making a flying car. And I just have to say, it looks very Jetsons-like. It's cool, and I can't wait to take my flying car to the office that I've been dreaming about for years.
Yeah. I mean, that's actually pretty slick-looking, isn't it?
It's very slick.
Yeah.
It's sort of like... I don't know, a cross between an it looks like one of these funky 3-wheeled super efficient electric cars, but with wings on it.
Yeah. And
look, it flies.
It does fly. Look at that. I'm not sure if this is on the market yet. I certainly hope not.
No.
But, this is not the first one of these, but it does look like the smallest one that I remember seeing. But I guess it might be worth mentioning that this story is just blowing up on our site.
It's incredibly popular. I mean, everybody wants a flying car, right?
Yeah.
And they're like, dude, that's the promise of the future, flying cars. I don't know how long it will be before we can actually fly our cars to the office, and considering how well people drive on the freeways around here, I'm not sure I want those same people behind the control stick of a plane.
I don't think so. I doubt if the FAA does either.
Yeah, there's probably, right, nasty little bit regulation to take care of there, and thank God. Before we go on to our guests, I'd like to take a minute to thank the sponsor of this podcast, New Relic. It's a software analytics company that makes sense of billions of data points about millions of applications in real time. It offers a comprehensive SaaS-based software analytics platform that empowers developers, IT people, and business leaders to transform their businesses by using real-time data that comes directly out of production software. It helps the people who build modern software understand the stories their data is trying to tell them. And now we're going to bring on our guest, Aneesh Chopra. He's the former CTO of the White House of the United States and is currently working with Box and a new company called Hunch Analytics. Welcome, Aneesh.
Thank you for having me.
Thanks for coming. I want to go back 1 year ago.
Yeah.
You wrote a guest post for us almost exactly 1 year ago
Yes.
about HealthCare.gov,
Yes.
which was really kind of in a sorry state at the time. And you had some pointers about what needed to happen next and where it was headed. So a year on, how does it look?
Much better. And in part, it's an embrace of the principles that were at the heart of the original HealthCare.gov that went live in July of 2010, which had the attributes of a lean startup where they embraced all the best practices. They tried some ideas, got feedback, iterated on the service, made it better, rolled out new features in 90-day increments, opened up the raw data so people could build more valuable insurance selection tools on top of the data. So those core principles that were part of the original HealthCare.gov are now very much at the heart of the what's considered Marketplace 2.0.
Okay.
And I'm very bullish and excited that this is going to be a dramatically better year.
Was that sort of the initial plan, that kind of iterative and lean startup approach?
Yes. This is the challenge of policymaking.
But it's not the most politically expedient or...
Well, all that is true. The original vision in the law was that each state would be its own startup. In fact, we funded, I think, $250 million to help about half a dozen states be early adopters of an insurance marketplace where the underlying code would be shareable and reusable so that nobody would have to reinvent the wheel, but we'd have the benefits of an entrepreneurial laboratory of democracy where states try new features, integrate with Medicaid or not, give you more data. For example, can I search by doctor to see which plans my doctors are in? These features would then be part of this, each state outperforming each other to be better and better and helping patients, consumers find the plans that are right for them. And that the federal HealthCare.gov was meant to be sort of a backstop, a raw utility that would be available for those states that couldn't get there.
Right.
And it flipped the model when the politics just got too bad
Right.
in terms of the states not really going forward on implementation.
So now that the politics has simmered down a little bit and we have some of these state exchanges that are actually up and running and working, is that federal level of healthcare.gov, is that actually working?
It's moving in that direction. So let's think of this in 3 tiers. At the center is the thing that the federal government alone can do: validate you're a citizen, confirm your income tax. All of that, what we refer to as the Federal Verification Services Hub. Actually, that part of healthcare.gov had been working even in the difficult first year. That back-end core system was working. The second piece is the actual user experience, the consumer shopping experience. And there, rather than embrace the principle of many better doors, we sort of had one, in this case, clunky door, and that became problematic when everybody was trying to bum rush the one door and it wasn't working. I think you're seeing in this environment now more of the philosophy of many better doors. So you could go to U.S. News and World Report, you can go to insurance brokers, and they can actually help you shop for plans based on that service. And then at the furthermost tier, there are all the value-added additional services. I think, for example, startups that say, if you give me your medical history, I'll tell you which plan is the right one for you based on your expected future health needs and the doctors that you've seen and all the rest. Those are early days, but they're coming. And I think we're going to see that play out over the next, this cycle and the cycle that follows.
Can you name some of those startups that are doing that kind of thing, that have emerged post?
Just as an example, Stride Health, which is a startup here in California, they're in the beginnings of the tell us your medical story, and we'll start to provide you recommendations engines. And I think as states like California start to open up the database of doctors that are associated with each of the plans, you're going to start to see opportunities for those 2 databases to come together. People can say, find me the best network for patients like me on the exchange. And that's not live today, but it's certainly in the realm of possibility. Hopefully, if not this cycle, then the cycle that follows.
Okay. Now, we're recording this at HealthBeat, which is VentureBeat's health tech conference, and you were just on stage with Aaron Levy from Box and Bob Kocher from Venrock. It was a very lively conversation in which you talked about how we're kind of at the 2-yard line as far as interoperability of patient records and the availability of patient electronic health records to the patients themselves. So can you say a little bit more about that?
Yeah, there are really 3 things that have happened simultaneously to put us at this 2-yard line, and the context might be helpful in describing where we are. The first is the payment reform provisions in the Affordable Care Act are just starting to take hold. In July of this year, Medicare released a list of the networks of hospitals and doctors who are going to get paid savings checks because they help both Medicare save money and improve care quality to patients. As doctors see that benefit of working in a different way come to life, they're demanding more data, which is one of the streams. The demand for data outside of the walls of your organization is now growing because of payment reform. Number 2, the blue button movement. The presidential statement that everyone should have access to their own data, starting with veterans, Medicare beneficiaries, and active duty military, has now voluntarily been adopted in large swaths of the private sector, from the retailers, Walgreens and CVS, all the way through doctors and hospitals who are under meaningful use obligations to provide that data. So the notion that data is now pointed out of systems to patients is a second thread that's now instantiated into rules. If you don't give patients an electronic copy of the data when they ask for it, you can be fined. The third trend is that we're starting to see the emergence of new health IT companies that are increasingly in the business of turning all of this plumbing into useful services that improve people's lives. And the chicken and egg has been, the more data I have, the more useful my advice to you and the better my app is.
Right.
And so you now have this situation emerging where people are starting to open up their data. consumers have the right. Doctors want patients to share back the unified record because it'll help them treat them better. They'll make more money as a result. And apps are emerging that will actually turn this into a beautiful, visually engaging experience for patients, something you're going to want to interact with. And I say we're at the 2-yard line because all of these things are technically true, but they're still clunky. The data standards, the plumbing that is facilitating the sharing of this data is not at internet standard. They're not at internet grade. It's still legacy integration points.
Right.
What seems to be emerging is a consensus among the vendor community in health IT to move to more of an internet standard, using OAuth, using OpenID Connect, and embracing web services, RESTful approaches for sharing data. And all of that's coming together right now to put us at that 2-yard line to punch it in.
So we still have 98 yards to go, or we have 2 yards to go?
2 yards to go.
Oh, okay.
Well, December is the next meaningful use rule, if it follows historical patterns. And if that rule embraces the notion that there shall be an API, at least to the patient and maybe even then doctor to doctor, that would be what I would call punching it into the end zone. At least the policy clarity will be there. It'll take a few years thereafter to actually implement, see the landscape emerge, the apps become successful, compete. So that's still a decade's journey to see all of this be put in place. But we can now see the blueprint, and there can be consensus on what that should look like. So we now know where we're going.
Right.
And the pace is going to be dictated by the pace of payment reform and a variety of other things, but at least we'll know where we're going. Right now, not so much. If I ask for a copy of my record from Medicare, it looks a lot different than a copy of my record from my doctor. It looks a lot different than the copy of my record from Walgreens. And some of them not even computable.
They're PDFs or something,
Could
right?
be all of the above.
Yeah.
By saying, no, here's the technical method by which you're going to expose upon patient consent their discrete data, that starts to allow for third-party applications to build valuable services on top.
Now, you mentioned on stage that there's a public API that a group
Call to action
that a group of advisors just recently sort of issued, right?
So, that's right. And so the specification is still to be determined, but they're built on something called FHIR, Fast Healthcare Interoperability Resources. This is the RESTful approach for exposing what was, in technical terms, the HL7 lingua franca. That is the de facto standards body in healthcare. HL7 has been pushing data in legacy systems, your blood pressure, your immunizations, your history, your medications list. And now all of those data elements are being mapped to these RESTful models so that they can be exchanged using more of the internet approach. So FHIR is the underlying technical standard that's getting the consensus. And how one actually implements it, there'll be some debate. But an example is smartplatforms.org, which was a federal government-funded R&D project out of Harvard, inspired by the idea of an app store for healthcare that's been at this for 5 years. And they're now getting implementations up and running to show you what it would be like to swap out your growth chart app for kids from what is ugly and clunky in the legacy system to something modern, web-based, more engaging to patients and clinicians. And they demonstrated you could swap out these modules at internet speed on account of tools like smart platforms.
And if it were an API or a standard interface,
you'll
then
see a heck of a lot more app
right?
development.
You'd be able to say like, oh, I don't like the way this looks, or I'd rather use this app or that app.
You
right?
got it.
Yeah,
you got it. And that's what we want in the industry, a lot more shots on goal as doctors and hospitals think differently about the questions they should be asking of their data so they can treat people under the new payment conditions.
So I've been saying for a while that health tech right now feels a little bit like enterprise IT did about 15 years ago.
Yeah, that's right.
When the IT vendors were kind of just discovering the internet and they're like, we know we have to do something about the internet, and they would sort of add a little layer of interconnectivity, but they were still fundamentally about, sort of protecting their silos and their proprietary systems. And what happened is some of them, Oracle and SAP sort of started adding deeper and deeper kind of interoperability and
inside their walls.
Inside their walls, exactly. But I think where a lot of the action came from was actually a lot of startups that kind of came in and took away the incumbents' lunch before the incumbents were forced to reckon with it. So what do you think the upshot is going to be for the American healthcare system as this kind of standards-based
I think it's a race.
Going to happen?
I think it's a race. So if doctors and hospitals respond to new payment incentives, they will be asking different questions of their systems than they're asking today. And the legacy vendors will have to ask themselves, are we going to be able to provide for them the answers to the questions they posed? Will we partner with startups to deliver that functionality, or will we open up our core interfaces and allow those doctors to pose those questions and choose in the marketplace? Mm-hmm. And any one of those three scenarios will compete with the others. Mm-hmm. There'll be some legacy vendors who will say, wait for the next version. We're going to incorporate all that into the base system, and it'll be reliable and secure, and you can trust it. Others will partner because they'll say, look, this is not a capacity that I have, but I'm willing to partner with a few select startups to bring them in and expand my offerings. And yet even others will say, you know what, I'm going to totally open up the platform. And if the doctor wants to add a module by going to a proverbial app store and download it with a few simple technical steps, because it's built on FHIR resources, mm-hmm. it can plug in without having to pay an extortion fee, enterprise integration services, and all these other barriers that have made that hard mm-hmm. for clinicians to operate. So I think all three will compete, and we'll see which ones emerge over the next decade.
Is that going to make a difference to patients or to the quality of care?
Absolutely, because we're all going to be competing on doing the things that matter. The beauty of healthcare right now is we're seeing incredible alignment. Lowering costs in healthcare is actually consistent with improving quality, not the other way around. Mm. This isn't about less and less, and so you have to eat your porridge. Rather, this is people are unnecessarily getting tests, people that can be treated in a much more preventive fashion, avoiding the need for more intensive surgery or medical admissions. So, in fact, consuming less healthcare resources and consuming more expensive healthcare resources less is actually in alignment with the patient's best interests. If that doctor is thinking about you when you're not calling them mm-hmm. and they anticipate that you might have fever and they can reach out to you and remind you to get that flu shot and be more proactive about these kinds of things, you'll be better off for it. Mm-hmm. And the systems that allow those providers to be more intelligent in terms of looking across all of their patients to say who are the 15 we should be calling today mm-hmm. is going to allow them to do that. And all of that will be innovation. And we're going to see either startups do it or legacy vendors get there. And that race will be all to the betterment of the patient.
Well, let me ask you about a very topical thing that's in the news a lot right now, which is Ebola.
Yep.
And how we respond to that, or how we coordinate around that.
Well, here's a great example.
Right.
We saw the screens first of all, let's make an obvious point. Health IT is not why we struggled in dealing with the case of the Ebola patient in Dallas. However, it could play a role in making sure that the capacity of the American healthcare system is upgraded. Mm. So what you heard there was that the questions on travel history were not as prioritized in the clinician's workflow. So they weren't really important questions. So they may get to them later. So the standard questionnaire for how a nurse or a doctor interacts with a patient in the emergency room looks maybe, different than you would if you were to roll out instantly around a new Ebola-oriented screening process. In the cloud, if we had a Workday-like vendor who could upgrade that template and allow everyone to have access to it minutes from now, mm-hmm. we'd be in a much better place. Instead, each hospital right now mm-hmm. has to manually rework their screens and their questions in order to prioritize travel history. Mm-hmm. They're getting there. They're going to ask those questions, and they're going to embed that because it's something that public health experts have said they should do. But it feels like 1990s, not 2014, right. that we're doing it without it being like write once and distribute many. Right. And we need write once, distribute many in healthcare. And so we're getting there, and we're going to start to see the benefits of cloud as these systems mature.
Okay. Before we wrap up, I want to hear about what your new venture is, Hunch Analytics. Tell me what you're doing.
Well, I'm focused on how open data can help improve the health, energy, and education markets. These are regulated sectors of the American economy, mm-hmm. where the opening up of data, in many cases new data, in this case access to personal health record data is just one example in healthcare. But I'm very much interested in how we look to these new resources as assets that, if combined with other databases, could inform better decision-making. As a small example, I ran a small little pilot project with Workday, LinkedIn, Monster, and others to map the unemployed veterans' skills gap. Mm. And the premise was, if every job posting in America could be deconstructed into a set of skills that are in demand, and every resume of every job-seeking veteran could be distilled into a set of skills they're looking for work, one could do a much better job of matchmaking, and more importantly say, hey, where are the 6-month training programs that if you took the time to work on could get you a much better paying job on the other end?
Mm-hmm.
And we demonstrated the art of the possible on how to repurpose open government data to help bring that. It's called veteranstalent.io, a little proof of concept. I'm investing in startups that believe in that philosophy. Healthcare is my primary focus. And so we're working on ways to improve digital marketing to healthcare patients in a secure and sensitive way, as well as empowering patients with their own data to be shared back with the providers they trust to take better care of them. And so we're looking at these at early days, not a lot to celebrate in terms of successes, but I'm hopeful that this is going to be the journey that will fix the industry, the journey of anticipating a patient's needs and making sure the healthcare delivery system can best support them before they get sicker, and therefore make the system work better for the American people.
Well, that's interesting. That's going back to what you were doing as the CTO of the U.S. in terms of open data, right? It's not just about healthcare, but as government data becomes open, published in a usable format, like it opens up all these opportunities for companies to come in
in financial services and education and healthcare.
Right.
I personally think that we haven't done as much to mine all of these newly available resources to their fullest extent. And part of it is I'm, putting my feet where my mouth is, or whatever the expression is, eating my own dog food. I believe there's economic opportunity here, and I'm demonstrating that in some of these early projects that we're working on at Hunch Analytics.
Okay, great. Well, it's been a pleasure talking with you. Thank you very much for taking the time.
Thank you for having me.
And we'll have to catch up with you in another 6 months or a year. And find out what you're doing then.
Thank you.
Thanks, Aneesh. And thank you for joining us for another episode of VentureBeat's podcast, What to Think. As always, you can catch us online at VentureBeat.com, and you can subscribe to this podcast if you haven't done so already on iTunes. Just search for What to Think. Thanks very much.